A man falls, hurts his shoulder, and asks, "What peptide should I use?" That is already the wrong first question. Let's walk through a real-world peptide medicine case. A male patient falls and injures his shoulder. He has pain lifting his arm, his sleep is poor, he's overweight, and he wants to know, what peptide should I use? But in Praxis Peptide Institute, we don't start with the peptide. We start with the pattern. First question, is this safe to manage conservatively, or does it need further evaluation? Was there a fracture, a dislocation, a full thickness rotator cuff tear, severe weakness, numbness, loss of range of motion, night pain that's worsening? If those are present, this isn't a peptide first conversation. This is an evaluation first conversation. Now, if the injury is appropriate for conservative management, the next question is, what tissue pattern are we dealing with? Is this a tendon, ligament, labrum, bursa, muscle, joint capsule, nerve irritation? Because shoulder pain isn't a diagnosis, it's just a location. Then we ask, what phase of healing is this patient in? Acute inflammation, early repair, remodeling, chronic compensation? Peptide signal means something different depending on the phase. This is where people oversimplify. They say, use BPC, use TB500, use a healing stack. But that skips the actual clinical reasoning. BPC is often discussed around local repair signaling, vascular response, inflammation modulation, and tendon or gut-related repair models. TB500 is usually discussed around tissue remodeling, cell migration, actin dynamics, and the repair environment. But repair peptide doesn't mean proven shoulder cure. It means we have a signal category. It may be relevant depending on the tissue, the phase, the level of evidence, risk, the legality, source quality, and monitoring plan. Now, here's the part most people miss. This patient doesn't sleep well, and he's overweight. That definitely matters, because tissue repair doesn't happen in isolation. Poor sleep changes growth hormone rhythm, pain sensitivity, inflammation, glucose regulation, and recovery capacity. Body weight can increase systemic inflammation, insulin resistance, mechanical load, and slower tissue recovery. So, if we only focus on the shoulder, we miss the system the shoulder is healing inside. The peptide may be one signal, but the environment determines how that signal is received. So the Praxis approach asks, what is the injury? What tissue is involved? What phase of healing are we in? What signal are we considering? What evidence supports that signal? What risks matter? What else is impairing recovery? What are we monitoring? For this case, monitoring could include pain with overhead movement, range of motion, sleep quality, morning stiffness, grip strength or functional strength, ability to get dressed, reach, press, or even carry, inflammatory patterns, and whether function is improving week by week. The goal isn't, did he feel something? The goal would be, is his shoulder becoming more functional, less reactive, and more stable over time? That's peptide medicine, not peptide guessing. Because a shoulder injury in an overweight person who doesn't sleep well is not just a shoulder injury. It's a tissue injury inside of a recovery system. And if the recovery system is struggling, the peptide is not the whole plan. The plan has to include evaluation, tissue diagnosis, load management, sleep improvement, metabolic context, nutrition, rehab, and only then a thoughtful discussion whether a peptide signal belongs. That is what Praxis Peptide Institute teaches: mechanism, evidence, risk, patient context, monitoring, and decision making. Because the future of peptide medicine isn't what peptide for shoulder pain. The future is what system are we treating, what signal belongs there, and how will we know if the body is responding?